hosted by Eric Halpern, who is a PharmD. He is a pharmacist and assistant manager of Fine Federal Dispensaries in Newington, Connecticut. Eric graduated from UConn School of Pharmacy in 2012, and prior to this role, spent 12 years working in community pharmacy, chain, independent, and grocery settings. Today, Eric will be discussing CBD, the medical marijuana program in Connecticut, and how it compares to other state programs, as well as his experience as a pharmacist in the program. So now I will turn it over to Eric.
Perfect, Dan. Thanks so much for that introduction. Welcome, everyone. There is a question and answer part of this Zoom. So if you'd like to ask questions there, I'll do my best to get to them. And at the end, we'll definitely wrap it up with all of your questions answered, because I know this discussion is something that's unique for a lot of people, whether you've had some exposure or no exposure. And I would love for everyone here to get the most out of it as possible. So we'll get started here. And disclosure, financial disclosure, I am employed, like Ann said, by Fine Federal Dispensary. We are in 3 locations in Connecticut, as well as locations in Grow in Massachusetts and Extraction in Rhode Island. And non-financial, I am on the board of directors for the Connecticut Pharmacists Association. So medical marijuana in Connecticut, the act was passed in May of 2012. So that was the same month I was graduating, which is why I wasn't even really on my radar as a career option when I was graduating from UConn. And what it did was create the structure for a medical marijuana program in Connecticut to provide patients with certain qualifying conditions access to medical marijuana. This didn't actually, the first sales didn't happen until 2014. It took a couple years for patients to get enrolled in the program and dispensaries and grow operations up and running. This program protects anyone involved from any state or criminal civil penalties, but it is still a federally illegal substance, so it's only protecting them from those state criminal and civil penalties. I haven't heard of anyone having an issue with this in my time in the program. Medical marijuana can only be dispensed by a licensed pharmacist. So Connecticut was the first state to do this, where they took the regular pharmacy laws and regulations, essentially took out the word medication, inserted the word marijuana, and that is how this business is run. So it's very similar to running like a retail pharmacy in the way that product is stored safely, inventoried, checked by pharmacists before dispensing. So it was a very natural fit for pharmacists to be dispensing these products that we are truly treating as medicine. Medical marijuana can only be sold from licensed dispensaries. So in Connecticut, there are no pharmacies that can stock a medical marijuana product, and medical marijuana dispensaries cannot obtain a pharmacy license to stock and sell typical pharmaceutical products. So we are not licensed as a pharmacy. And working here, technically, I'm not a pharmacist. I am a dispensary. In the legislation, that's what they call the registered pharmacist who is dispensing these products. As of this month, there are over 50,000 registered patients now. We saw a big jump when chronic pain was added in June of last year. Prior to that, there were qualifying conditions where pain was a primary symptom, but chronic pain in and of itself was never a qualifying condition on its own. The state has 4 producers. They're all indoor grow operations, and their legislation allows for up to 10 producers. But the state started with 4 back in 2014, and they haven't opened up any application period since for any other producers to build out in Connecticut. We have over 1,000 registered physicians in the state who provide medical marijuana certifications, and there are 18 licensed dispensaries in the state. This started as 6 initial dispensaries when the program started up, and then it expanded to 9 dispensaries. And then the final application period, which is where we won a license in Willimantic, Connecticut, was December of 2018. And since then, there hasn't been any more open application periods, and I don't think there will be, given the nature of we have adult use coming down the pipeline probably at some point next year. And now most parts of Connecticut are covered with a dispensary, so patients don't have to drive very far to get to one anymore. This is a list of the approved conditions for treatment with medical marijuana. The ones in the beginning here were some of the initial qualifying conditions, and then it's just expanded since 2012. And the way that these conditions get approved is there's a board of physicians who work with the state to recommend medical conditions to be added to this list. It could be done through legislation, but that has not happened yet. And citizens can petition the state to add a qualifying condition to this list and provide some evidence and testimony about why conditions should be part of the medical marijuana program. So the beginnings, more common ones, there's a lot of rare diseases and disorders here. PTSD is the one qualifying condition that is a mental health condition. And that's what over 50% of our patients have that as their qualifying condition. Cancer and chronic pain would be the next two most common qualifying conditions that we see here. There are pediatric patients in Connecticut. The list is not as extensive as the adult list. These patients cannot purchase anything that is going to be inhaled, such as flower, vape, pre-rolls. And here we only have a couple patients who are under 18, mostly for epilepsy. And I don't know the numbers for across the state, how many pediatric patients there are, but I don't imagine that this is a very large patient subset within the 54,000 patients we have across the state. Like I said, in Connecticut, this was the first program to involve a pharmacist in the dispensing of medical marijuana products. Minnesota, Aaron and I were talking just before this, was followed up just a couple years later. And there are some other states that involve pharmacists, such as New York, Pennsylvania. They're all in different capacities. Here in Connecticut, we do everything. We're involved in patient counseling, which I'll get to. We're involved in dispensing. In other states, they'll have healthcare professionals to provide the counseling service, but they may not be as involved on the dispensing side of things as we are here. So what does a cannabis pharmacist do? So the biggest part of our role, and I think where our pharmacist and communication skills really comes into play, is patient counseling. Every patient here who comes either brand new to the program, and they may or may not have cannabis experience, or they're transferring from another dispensary, receives a consultation with us. So we'll discuss their health conditions, their current medication list, their previous cannabis experience, if they have any, what preferences they have. Some people come in here and they don't want to smoke anything. So we will work with them to figure out what we should recommend based on their preferences, how to safely use it. We have some products that are microdose. We would say 5 milligrams of THC, all the way up to capsules that are 100 and 200 milligrams of THC. So there's this very large learning curve about how to go about choosing products from our menu. In Connecticut, I'm sure across the country, physicians are not truly prescribing any product. So it's not like a typical pharmacy where the patient's coming in and we're being told what to dispense. We have a menu of around 500 different medical marijuana products that any one of our registered patients can choose from. We're here to help advise them along the way. We aren't prescribing anything, but we make some strong recommendations, and there are patients who certainly depend on that to be able to go through the program and have successes and not be overwhelmed or have negative experiences. Another huge part of our role here is inventory management. All products that come to us from the 4 growers are already pre-packaged, so we're not weighing anything, we're not counting anything out, we're not baking anything here. It's really all packaged, ready to go for the patient. We just have to put a sticker on it, which has their personal information. But all this product has to be locked in a vault that is just as secure as your typical safe that you'd find C2 products in a pharmacy, because according to Connecticut, these are C2 products. The difference being with this is that pharmacy technicians who are registered as our dispensary technicians can handle these products. All of these products have to be kept in this highly secure vault and require a full inventory once a week. So one evening after we close, each week we'll go through the entire inventory, print out what we're supposed to have, count down how much we do have, and then see if there's any discrepancies that need to be reported or resolved. This vault can only be accessed by registered pharmacists and our pharmacy technicians who are working as our dispensary technicians. So we do have some staff here that are not licensed pharmacists or technicians, they don't have access to that part of the operation. Lastly, staff management, another very common role that a pharmacist may have in a management position in a typical retail pharmacy. We're responsible for supervising our front desk and security staff, as well as all of our technicians. So we are working under the same ratio as a retail pharmacy in Connecticut, which is 3 technicians to 1 pharmacist. That was increased during COVID with the emergency order from our governor to 4 to 1, but now we're back at that 3 to 1 ratio. So that makes for some interesting staffing difficulties, because during our really busy drive times, we have a technician at every register, as well as technicians in the back helping us fill. That requires a lot of pharmacists to be on duty at the same time. And this is just like a typical pharmacy where the business can't be open and operating without a pharmacist on site. So I'm the assistant manager here, and my partner Dennis is the manager here. And we are also the pharmacist in charge. So we're responsible for making sure the day-to-day operations go smoothly, working on sort of our larger goals as a company, and working on hiring and training all these staff. Medical marijuana and cannabis in general works with the endocannabinoid system, which is a system that is in all of our bodies and is involved in different homeostatic mechanisms. An acronym that I love, and on the next slide I have a better breakdown of it, is PREFACE, which is protect, relax, eat, forget, sleep. If anyone has ever had an experience with cannabis before, you know that it can be very, very relaxing. You know that it can cause the munchies. So that is actually one of the great side effects of it for our patients who are having wasting syndrome or going through chemotherapy and totally lose their appetite. It can really, truly stimulate appetite. We have some patients who wish it didn't, but it's a hard to avoid side effect with cannabis. Forget, for patients with PTSD or other mental health conditions, some patients can only get through their day if they're able to put aside their trauma and be able to move forward without having their trauma be overwhelming and throughout their life. And sleep. Sleep is one of the biggest things we talk about all day, every day with people. Pain, anxiety, sleep, I would say, are the 3 main symptoms that we discuss. And sleep can be improved with cannabis. It's interesting because it actually reduces the amount of REM sleep, but it doesn't reduce the sleep quality. So patients get less deep sleep, but they are getting more time asleep. The 2 main receptors in the endocannabinoid system are called CB1 and CB2. CB1 is the receptor that is responsible for the psychoactive effects of cannabinoids, specifically THC. This is a receptor that's very rich in the central nervous system, whereas the CB2 is primarily in the periphery, not involved in the same psychoactive effects that CB1 is. In our bodies, we have endocannabinoids that naturally occur and are created on demand that interact with this system. Anandamide and 2-AG are the 2 main endocannabinoids. And interestingly, when someone consumes CBD, it actually stimulates the body to produce more of these endocannabinoids without producing an intoxicating or psychoactive effect. This is the acronym I was referring to. This is a nice chart that helps break it down a little bit more about protect, relax, eat, forget, and sleep, and how cannabis can affect the endocannabinoid system to have these different functions. THC and CBD are 2 acronyms that I'm sure you've heard of before this presentation, but they are structurally almost identical. It's just about the location of a double bond, but this slight variation in organic structure affects how these molecules interact with the CB1 and CB2 receptors. THC directly binds with the CB1 receptor, which CBD cannot. What that means is THC is the main component of the plant that's producing psychoactive effects. It can have pain-relieving effects. It can help relieve inflammation, increase appetite, like we discussed with the munchies, reduce spasticity, but it can also have side effects such as panic, anxiety, especially, I'm sure you've heard of people who use an edible and all of a sudden they go to the hospital because they think that they're physically ill. These are all potential side effects of THC, which is why we as pharmacists are always advising patients to use a small dose at first, see how it reacts with them, because for some patients, a little bit can go a long way. CBD, on the other hand, is not directly interacting with the CB1 receptor. It's modulating some of its activity. And it is very common now, especially with hemp varieties of cannabis. Hemp is technically a cannabis plant that contains less than 0.3% THC, which is essentially a negligible amount of THC. It's not intoxicating. I try to avoid the term psychoactive because yes, it can have some effects on things like anxiety, mood. So we try to say it's not intoxicating. So a patient could use this product and still be able to drive, go to work without worrying about it affecting them negatively. And also, interestingly, it can eliminate some of THC's unpleasant adverse effects, such as the panic, anxiety, sedation that we talked about, because it competitively binds with THC, or it changes how THC binds at this CB1 receptor. In 2018, the Farm Bill was passed that allows farmers to legally grow hemp and retailers to sell CBD products. But they do not have to undergo any FDA testing for safety or efficacy. This is a supplement according to the state. It's not according to the FDA, it's not being treated as a over-the-counter medication per se. So with CBD, it's one of over 100 identified compounds of the cannabis plant, and it's primarily in the leaves and flowers of the plant. It's likely the second most significant cannabinoid after THC and what we see in the raw flower. When it's sold over the counter, it is coming from the hemp plant. So again, that very low to negligible THC percentage. It's grown in Connecticut and across the country, and they cannot get you a quote unquote high. So this is a huge misconception out there. Is companies will, especially I've seen in the beverage space, will market something with CBD, put a pot leaf on it, make people think they're going to have some euphoric effects, but it just cannot do that. It doesn't have the physiologic capacity to do that. When patients are shopping for CBD, I always recommend to read the label very closely. It should always say how much CBD is included in each unit that's consumed, such as a gummy, or the entire product, such as a lotion or body balm. And the best ones have what's called a COA, which is a certificate of analysis. The requirements for this are different from state to state, but what a COA does, it shows that the product has been tested for the amount of CBD, the absence of THC, as well as for things that shouldn't be in the finished product, such as mold, fungus, heavy metals. Because of CBD's classification, there are certainly products out there that are misbranded with incorrect information on there about how much CBD is truly contained in it. And there can certainly be some dangerous products that have some things that people shouldn't be ingesting. It's just a confusing marketplace right now. There's a company called Green Roads, which I don't have any affiliation with, but they're actually a pharmacist-started CBD company. Excuse me. If patients are looking for a CBD shop online, that's a direction I will often send them, because they are all very clearly marketed, labeled, and started by a pharmacist, which I think is really interesting. The only approved CBD product from the FDA is Epidiolex, which is specifically for seizure disorders. And so any marketing or labeling of CBD products for any other medical use is illegal. So they can't say that it's going to relieve anxiety. They can't say that it's going to help sleep, but you'll see all over the place products that market themselves as sleep aids, and they'll contain CBD, maybe with some melatonin in them. So it's a very large gray area right now on what's going on in the CBD marketplace. People may use CBD for things like pain, stress, anxiety, sleep, digestive issues. And just like with THC, we always say to start low and go slow. Usually 10 to 20 milligrams of CBD consumed is a good place to start. So you'll see a lot of gummies out there that are somewhere between 5 to 25 milligrams. That's generally a good starting dose. I always recommend to use it during the day and not at night, because for some people, CBD can actually be stimulating instead of sedating and keep them up at night. Some patients expect to consume a CBD product and immediately feel something, kind of like if you were to have a drink and you'd feel that sense of calm, or if you'd have a typical THC product and you just get that sense of relief. With CBD, it's much more subtle than that. So it's not something that patients should feel like it's not working if they do not feel an immediate effect. And it can have side effects: drowsiness, insomnia, decreased appetite if patients use enough of it. So that's something we talk about with our patients who are trying to stimulate appetite, is to really try to not use too much CBD, because it can counteract any appetite stimulation effect they're getting from cannabis products. There are also cytochrome P450 drug interactions, such as Coumadin, amiodarone, verapamil. Because it's metabolized by 2C19 and 3A4 primarily, it can have inducing and inhibitory effects on other medications. So during our consult, that's something that we talk about with people when we're reviewing their medication list, is what they're taking and how that may or may not interact with medical marijuana. The tough part is we don't have a lot of data about these interactions because of the federally illegal classification. So we have Epidiolex to try to tease out some CBD interactions. We have Marinol, which is a synthetic Delta-9 THC, to try to tease out some potential THC interactions. But this really isn't all-encompassing, because a cannabis plant has over 100 different cannabinoids. So if we only focus on THC and CBD, we're not really getting the true picture of a potential drug interaction. Most of them come up as moderate, just say to monitor therapy, monitor for side effects. Opioids is the one medication that comes up as a black box warning, and that's due to excessive sedation. So it's not due to inhibitory or inducing effects necessarily. So this is a hot topic, and I really think pharmacists will be at the forefront as this becomes more accepted and researched across the country. And I think pharmacists are going to be in a great position to truly understand these drug interactions and be part of the change of helping medical marijuana be a product that can be used with some more guidance than honestly that we have now with the data. Latham had a great comment here. The most common question about cannabis is, will it interact with my medications? And it is always sad how little I can offer them as an answer sometimes. Totally agree with you there. I wish I had more information, and I'm sure if I was given this lecture in 10 years, we would have a lot more to work off of. All right, so another component of the plant other than the cannabinoids are terpenes, which isn't something that's unique to cannabis, but it's actually in many plants in nature. And essentially it gives a plant aroma and flavor, but in cannabis, we look at some potential medical benefits. Again, now this is something that isn't widely studied, so we are sort of extracting information to use these as suggestions for patients. But if patients are looking to improve a certain symptom, such as pain, we can talk to them about how myrcene is a terpene that is going to potentially provide more pain relief than other strains that do not contain that terpene. Limonene is a terpene we look at for anxiety and depression. Linalool can have a very relaxing effect. Humulene and beta-caryophyllene can be helpful with inflammation. We don't know percentages, though, that really make a significant effect. So it's absolutely not an exact science in evaluating the terpene profile and knowing exactly how it will react with the body. But we use it to try to pick out among the sea of products which ones may be the best ones for a patient to start off with. This is a graphic from Leafly, just offering different common terpenes, how they taste, how they can smell, and the effects that they can have. Marissa asked a great question. Eric, can you please share some reliable resources for pharmacists to turn in answering patient questions or to personally learn more about the topic? I actually have my last slide. I recommend a book called Cannabis Pharmacy, which is easy enough to remember. That was what I read before I started this job, and I say it honestly gave me about 80% of the information I needed to start this job. The other 20% being on the job training, talking to coworkers, especially learning about the usage of cannabis, not just the products themselves. And then there's a couple online publications that I recommend as well. There are 3 main strain types of cannabis, and this is something that is used across the country. So these are terms that if you looked at any marijuana menu of any retailer in the US, it would have these labels. Sativa strains are ones that tend to be more stimulating, uplifting, energizing. A lot of patients say this is something they use during the daytime to help get their day going. But this is also the strain type that is most likely to cause anxiety if people are prone to it. So we always say for anyone with any sort of anxiety as an underlying condition to either stay away from sativas or be very, very conservative in using them. Indica is the opposite. We say indica into couch because it can cause couch lock. They're very sedating, relaxing. Patients who are using this for pain report that indica strains tend to be the best for their pain. And most people just use it during evening and bedtime when they're really looking to relax, work on that sleep. Some patients can be functional with it during the day, but for a lot of people, it's just too sedating. Hybrids are something in the middle, and it's in other states called either sativa dominant, indica dominant, or neither. Here in Connecticut, they're all just called hybrids. And essentially, it's something that has been a cross of different strains and isn't purely an indica or sativa. With all of this, these aren't scientific terms. So these are terms that are used depending on the physical appearance of the plant. For instance, a sativa strain is usually taller with thinner leaves. An indica plant is usually shorter with broad leaves. But people can smoke a sativa and go to bed, or people may smoke an indica and feel energized. So I think this is going to be outdated information and nomenclature at some point. I don't know when, because the marketplace really does depend on these terms right now, and patients expect to know them when shopping. But I think eventually the terpene profile may be a better predictor of effects, and someday I think we'll have the genetics really mapped out and be able to more scientifically and quote unquote medically know the potential effects of a strain. And remember, it's a plant. So if the plant is being grown in Connecticut and it's being grown in California, it's going to be an indoor grow here and probably an outdoor grow in California with different soil content, different water content, different nutrients. So it's not like a medication where you're getting a manufactured product that's exactly the same every time. Even the same strain that the producers will make will vary in THC percentage and other cannabinoid percentages from time to time. So as great as 10 or 20% difference. So very, very significant differences. So here is a very big difference in using cannabis as medicine versus a traditional factory-made medication. We always say to start low and go slow with THC because it can have biphasic effects. Low doses tend to be really helpful for things like anxiety, but high doses can worsen it. So we always recommend patients try to find that sweet spot where they get symptom relief, but don't experience adverse effects. Interestingly, they've looked at with pain and they've found that higher doses of pain, higher doses of THC don't necessarily equate to better symptom relief, especially as it applies to pain. There's thought to be some point of saturation of CB1 receptors where you get to a point where they really just downregulate and THC doesn't have anywhere to bind to and you lose that medical symptom relief capacity. With something that's going under the tongue or ingested, a microdose such as 2.5 to 5 milligrams is an appropriate place to start. And we say patients can increase the dose every 2 to 3 days. In recreational markets, there are a lot of gummies out there and they tend to be 5 milligrams, which is right in this microdose range. Because CBD is not intoxicating, the dose can be adjusted a bit more frequently and a little bit higher, 10 or 20 milligrams to start. In Connecticut, we have a lot of different routes of administration and the product availability is certainly different from market to market. I think Connecticut has one of the most robust product selections, with the exception of we're not allowed to have candy or beverages from the growers. Inhalation, being the raw flower or vapes, is certainly the most common way that people use cannabis for a couple of reasons, and I'll get to that in a moment. We We also have different products that are swallowed, such as capsules, tablets, pre-made edibles. Again, we're not baking anything here. It's already all done. Honey, oral solutions, and tinctures. And then products that can go sublingual, the same oral solutions and tinctures. We even have something that's like a Listerine slip here. And then lastly, topical. So there's creams, lotions, body balms. And some of these products may contain just THC, some may contain just CBD, and then some may contain a combination of both. Even if a product is just CBD, you still have to be a medical marijuana patient to purchase that from our dispensary because it's coming from one of the 4 licensed medical marijuana producers. Inhalation is the most popular way because number one, it's the most cost effective. It's the cheapest way for a patient to purchase something here and medicate at home. Also, you can feel it the quickest because it's going directly from the lungs into the bloodstream. Within 5 minutes or so, you can expect to feel some effects, but they don't last very long, maybe 1 to 3 hours at most. So obviously as a pharmacist, we're generally not used to recommending inhaling smoke as a form of medicine. But in this case, if someone is looking for the quickest relief, this is the way to achieve that. With the flower, burning that, whether it be in a joint or a bowl or a bong, is the harshest way to consume because you're burning plant material that you're breathing in along with THC, CBD, other cannabinoids, and terpenes. Vape oils are an extracted oil from the plant that's mostly just THC with a little bit of plant material. And what you're breathing in is not nearly as hot as smoke. So for patients who already have respiratory issues but are looking to consume via inhalation, this is what we'd recommend would be a vape oil and using it at a very low voltage, meaning that what they're inhaling is not going to be very hot. The disadvantage is, especially with pain control, is that this does not have a long-lasting effect. So if someone's using this for chronic pain, for a lot of people, obviously smoking all day isn't going to be a realistic option. Swallowed is very different from smoking. So again, the typical experience you hear with edibles is someone eats half a brownie and they don't feel anything, so they eat the other half of the brownie. They still don't feel anything, so they eat a second brownie, and all of a sudden it hits you like a brick wall. The reason is that it has to go through first pass metabolism. So delta-9 THC, which is the active form of THC, is converted to 11-hydroxy THC, which is even more psychoactive and potent than THC. So you can expect to wait up to 2 hours to feel effects, but then those effects can last up to 8 hours. We have food items that contain measured amounts of THC. I like to recommend the capsules and tablets because you can more accurately know exactly how much is ingested, whereas with the brownies, for example, they're 20 milligrams each. So if I would like a patient to use 5 milligrams, you're trying to cut this brownie into 4 pieces, and who knows if every part of the brownie has that THC dispersed equally. The advantage is the dosing is very easy to control. So when we're recommending microdoses, we can say start with 1 tablet. And it's a much easier to measure than something that is smoked. And the effects are very long lasting. So if someone's looking for relief for something they can take in the morning and it can get them through the afternoon, this would be the way to go. There are absolutely variations in effect due to metabolism, and this doesn't have anything to do with BMI. It doesn't necessarily have everything to do with tolerance. It just has to do with people's metabolic capacities. So there are some patients who 5 milligrams can achieve them symptom relief, but other patients need 100 milligrams to achieve symptom relief. So we always have people start low, but there are certainly people who do require more to produce an effect. Sublingual gets you effects a bit quicker than digested because it goes right from oral mucosa into the bloodstream. So you say usually within an hour you feel the effects, and it may last about 4 to 6 hours, so almost as long as an edible. This can be very discreet. For instance, we have pictured here an oral spray that is alcohol based, and what that does is allows a patient to have it on their person if they need to medicate discreetly and get a quicker effect than they would with a capsule or tablet. But a lot of them are alcohol-based, if they are truly tinctures or oral sprays, which can be very unpleasant and provide and give a very strong stinging sensation under the tongue. Topical will be the last one. This may have an onset between 15 to 60 minutes, may last between 2 to 6 hours. I always tell people, it's probably one of the safest things to use, and because it's not getting absorbed into the bloodstream, but it's hard to predict really how quickly it's going to work and how long it's going to work. So we have a variety of topicals here that either are just THC, just CBD, or both. The skin has the same CB1 and CB2 receptors as the rest of our body. And THC seems to be more effective for pain topically, and CBD more effective for inflammation topically. So these are very easy to use. I have a lot of elderly patients who come in, and this is the only thing they want to start off with to see if it can relieve their symptoms, which is great because you're not worried about the psychoactive effects that could lead to fall risk, or not worried about drug interactions with our elderly patients who are already on a lot of polypharmacy. So it's a basically low risk way to try to use THC and CBD to relieve their symptoms. There are certainly precautions with cannabis. So smoking can lead to lung-related illnesses. It's not something that should be recommended all the time for patients. It is absolutely the most popular product that's purchased here, and it's certainly the most common way of ingesting cannabis. But for a patient who already has COPD or asthma, we really try to work with them to find something else versus adding an additional irritant to their respiratory system. Operating machinery or driving under the influence is strictly prohibited. Just the same as you would expect with alcohol. Anytime something like this is consumed, it can affect memory, it can affect reflex time, it can affect logic. There's something called time distortion, where time seems to flow differently when you're under the influence of cannabis. So no one should ever be driving. I always recommend, especially when using this in the beginning, to just be home, be safe, be comfortable. We say mindset and setting have a lot to do with the experience with cannabis. Mindset being, are you relaxed? Are you expecting a positive experience? Setting, are you in a place where you're comfortable, a place that won't make you anxious if you start to feel uncomfortable? So I always say, try to be home, be comfortable, have your schedule cleared for the day until you really know how this affects you. Also, cannabis can lead to patients being at risk of developing psychosis. This is something I've seen once since I've been here. I haven't seen a lot of it, but THC can certainly precipitate psychological symptoms in our patients who have mental health conditions. So it's something, when we have patients with bipolar or major depressive disorder, we'll have those real conversations with them during the consult about, yes, this may help you relieve some symptoms, but we should proceed with caution and make sure that we're not changing your mood, not changing your perspective, and making sure they're safely using these products. These are a few resources that I love. Cannabis Pharmacy is available on Amazon and on paperback and Kindle. This is the book that I use to sort of get myself caught up to start this process of becoming a cannabis pharmacist. CRX Magazine has some great clinical information that I think is really geared towards pharmacists and healthcare professionals in the field. And then the American Journal of Endocannabinoid Medicine, which seems to have slowed down a bit since COVID. This is more of a medical publication, the really nitty-gritty, sciencey stuff, if you would like to geek out on that. But these are some resources I've found helpful in my journey of learning, and this is very much a continued process. Cannabis, there is new information coming out all the time. There's a lot of interesting things going on in the industry. Because it's federally legal, each state has to grow, process, and retail that cannabis in the same state. So across all the different states who have these different markets and laws, there's a lot of different products out there and a lot of different trends. And I think there will be more studies coming up where we're going to have more true information about how this is working. In Connecticut, Yale partnered with CT Pharma, one of the growers who's in Rocky Hill, to work on getting patients in the study capsules that contain varying amounts of THC and CBD and measuring different endpoints. So that was the first FDA approved study of its kind. And I think we're going to see more of that coming down the pipeline. So that's all I had for the official presentation. I'm going to stop sharing now and bring us back to the main screen here. And I was able to answer some questions along the way, which is great. And let me just read these last couple here. Can you repeat the website you recommended for online CBD that's run by pharmacists? So Green Roads, I'll type it in here. Green Roads. You know, I don't know if that's the exact URL, but that's the brand that I have the most trust in when it comes from an online retailer.
Thank you, Eric. I went to the CRX mag because I was like, ooh, that sounds great. I should subscribe. And I totally expected my clinic's firewall to stop me, but it didn't. So it must be legit. Or at least not questionable.
Yeah.
Any additional questions for Dr. Halpern? I just have a curiosity question, I guess. Were you, so you essentially graduated and at the same time that the law was passed. So were you in it from the ground up? Like, were you in it those 2 years where they were trying to figure things out?
Great question. So it was on my radar because my first boss ever from Walgreens was opening up one of the original 6 dispensaries. So he was leaving Walgreens after being there for 25 years to work in this uncharted territory, in this industry that was brand new for pharmacists to be involved in. So I kept my ear to the ground. I went to continuing education programs. I would talk to him along with other pharmacists that I knew who left retail to go into it. So it was on my radar for a while, but to be honest, for me personally, I wasn't ready to take that leap until this opportunity with PharmD came around. A lot of the companies are owned by large multi-state operators. PharmD is a locally owned family small business, so it has a true startup feel to it. So that type of thing is an opportunity most pharmacists never get the chance to do, is be part of something brand new and build it up. So when we opened here in Newington in September 2019, I was me and Dennis were the 2 pharmacists here. We started with 1 technician, 2 front desk staff, and now we're way bigger than that. And it's really been a fun adventure building up from nothing. Yeah, that is cool. It looks like we do have some questions here. I have these here and I can run this. So are you ever concerned about diabetes and the munchies side effect? Absolutely. So munchies is pretty much an unavoidable side effect of THC. So what I try to tell patients is, if they're using it for sleep, just try to use it as close to bedtime as possible. So hopefully you're sleeping before the munchies kick in. Especially, we have some very sugary edibles, brownies, cookies, honey. So we're always advising our patients with diabetes, try to stick to things like chewable mint tablets and capsules, things that aren't going to potentially worsen their diabetes. And then Anna asks, where can we find our state's laws regarding medical marijuana prescribing and dispensing in approved conditions? So in Connecticut, for example, we have our Department of Consumer Protection, which is the regulatory body that oversees our medical marijuana program. Every state, I'm sure, has a different department that does this. I would honestly I don't think there's a central repository for this information that I'm aware of, at least. I think you'd have to go state by state and look through their government website to see what they published about the medical marijuana program. For instance, I looked at Massachusetts because that's our neighbor, and navigating their program is a bit more complicated than when I go to our state's program and try to learn what those qualifying conditions are, especially because in Massachusetts, for example, there isn't a list that has to abide by. A prescriber can certify any patient who they think would improve with medical marijuana. They don't need to have a certain qualifying condition. Let's see here.
I did throw in the chat a website that I think is pretty good to start with. It gives kind of a global overview of the 50 states and kind of what they allow, but I would start there and then kind of go into depth into the more specific state that you're interested in.
Yeah. Deborah asked how we find reputable and knowledgeable providers to refer our patients to if they're looking to be treated with medical marijuana. So honestly, I would refer them to a local dispensary because the physicians who are involved in the program don't necessarily have any continuing education on this. In Connecticut, any prescriber who can prescribe a typical controlled substance is eligible to prescribe certify patients for medical marijuana. So most of them aren't really apt to educating patients on the products. That is put on us as pharmacists at the dispensary. So I would suggest connecting that patient with the dispensary in the area. They can reach out to me personally. I'm happy to talk to anyone about this. And then we can let patients know what resources are available in the area for getting certified. Does your dispensary have a mechanism for patient follow-up to assess symptoms, or is that primarily through the PCP? So we don't have a necessarily software or database to track follow-up. We do record patients' initial self-assessment of symptoms. We have some patients we have some pretty extensive notes on because we're constantly having conversations with them about their treatment and about their improvement and difficulties, but there isn't any central place where we do that. To be involved, currently P4, how would I get involved in this field? So in Connecticut, at least, keep an eye on all these different dispensaries, especially later this year into next year. It's going to get a lot busier, especially with adult use coming on board. And even with adult use, it will be a hybrid license for places like us, where a pharmacist is going to be in charge of the whole operation. So unlike in Massachusetts, anyone could be a bud tender, anyone could be a general manager. In Connecticut, it's still going to be pharmacists who are running these operations. Do you recommend avoiding anticoagulants in combination with CBD, THC? What are your thoughts on these drug interactions? So certainly patients who are on warfarin, we talk about the potential severity of that interaction. If someone is starting cannabis for the first time ever, we're still going to recommend low doses, but I would recommend having their IRNR checked in 4 to 6 weeks to see if there's been any effect. For me, a lot of the patients that I've counseled on this have been using cannabis already before they were even on Coumadin. So it hasn't come up as a clinical issue as of yet for us at our dispensary. Why dronabinol hasn't ever been used widely versus cannabinoids? So dronabinol is really just approved, I believe, for AIDS-related appetite stimulation and cancer-related appetite stimulation. I don't think it's been really studied in other contexts. And to be honest, it's sort of a crummy drug to work with. It has to be refrigerated. It comes in these little gel caps that stick together. It comes as 2.5, 5, and 10 milligrams. And now we have generic, but initially when it was just Marinol, it was so expensive. So because it's also a synthetic Delta-9 THC, you don't get what's called the entourage effect, where all these different components of the plant that are exerting a medical benefit versus just one isolated piece of it. The different types of anticoagulants. So it's really Coumadin is the anticoagulant that we're the most concerned with. The other ones don't have the same sort of drug interactions. Great questions, everyone. That's great advice, Rebecca, saying that any patient who's on Coumadin and using marijuana, that they just need to keep their use consistent, just like we would tell someone about eating spinach and leafy greens. Like if you're gonna do it every day consistently, then we're gonna stay in the same INR therapeutic window. If you're gonna be all over the place, that could potentially create a problem.
Any other questions out there? This is great. I mean, seeing none right now, we can wrap things up. Eric, do you mind throwing your email in the chat function real quick? If anybody has any off chat questions. He already said he was fine to talk to people, so.
And if anyone's on Instagram, I actually have a a geeky Instagram account where I post about different products and different things going on in the industry. So that's my my name on Instagram if you want to find me there and see what's going on, especially in the Connecticut industry.
A really great presentation. Thank you, Eric.
My pleasure. Yeah, thank you all for listening. You know, I know it's a hot topic and it's something that a lot of pharmacists aren't exposed to, and you're only going to get more questions about it. And people are truly looking to use this for symptom relief and medical purposes. And us as the drug experts, I think we have a huge opportunity here as this industry gets larger to be the leaders and be at the forefront of this revolution of taking something that's been illegal and stigmatized and turning it around into something that can be normalized and therapeutic.
Well said.
All right. So you all have